for NCLEX exam. So geriatrics, what kind of questions are we gonna get? Now, first of all, keep your mind in the fact that, okay, when I have a gero patient in front of me, what should I really worry about? What should I be thinking about? Their memory, their physical health, their energy level, what is it like? So you have to also put that in here in this question as you're answering the question. Always think about your role as a nurse. What can I do for this patient? How can I support this patient? Does it make sense? Keep the population in mind. Anytime they mention a case, for example, whenever, whether Gero or any question, and they say a 78-year-old keyword, that puts you into general population, or an 8-year-old keyword. That's a pediatric population right there. Or they say a 35-year-old pregnant mom. That will now switch the dynamic of your population. They said 38-year-old or 35-year-old woman, that's one population. Now they now had pregnant woman. That will now change the way you're going to think about that question. So start thinking about the population, and of course other keywords that follows that says report what difficulty remembering event. Report difficulty remembering event. Can you kind of see how I'm systematically reading the question? That's how you're going to be focusing on, reading questions and picking out the keywords. So what are your keywords? It is age, it is sex, it is situation, it is time, duration, and of course, situation. All those things are your keywords that you have to look at. And then once you're done looking at it, you now say, okay, what exactly is the question asking me? What exactly are they asking me? So a 78-year-old patient reports difficulty remembering events, but can recall past events clearly. What type of memory loss is this most consistent with? A, short-term memory impairment. B, long-term memory impairment. C, global memory loss. D, age-related change. Nurses, future nurses, what do we think the answer is? All right. Thank you so much. Please do your best to participate. The more you participate, the better you get. We're going to spend just 1 minute on this question and keep it moving. I'm seeing a few A's. I'm seeing mixed answers on my end here. So now, if I need you to go ahead and take two answers out that is not, always answer questions like this. Always remove what you think it's not going to be. A 78-year-old reports difficulty remembering event, but can still recall past events clearly. Okay, can still recall past events clearly. We knock out 2. We knock out B. Can still remember something. We knock out C. Global memory loss. And then what about normal age-related change? We're going to hold on to A. We're going to hold on to D. Always remove 2. Okay, when we have 4 problems, is a big problem. When we have 2 problem is manageable. Well, depending on how big the problem is too, though. Some 2 problems feels like 40 problems. So, but in this case, let's say 2 problems is better than 4 problems. So you remove 2, okay, you have 2 left. Out of these 2, this is brutal. Golly, how can you say that it is so normal for our aging people to have memory loss, to forget things, to forget themselves, to forget their keys? Absolutely not. A is the final answer here. Thank you so much for participating. Let's look at the rationale quickly. Short-term memory impairment. Okay, short-term memory declines with normal aging, while long-term memory is generally preserved. Global memory loss or rapid decline may indicate dementia, period. So long-term memory usually remains intact in normal aging, so that's not correct. Global memory loss suggests advanced dementia, not normal aging. Short-term memory changes is beyond more minor forgetfulness is not normal. Now, number 2, which tool is commonly used to assess cognitive function in older adults? A, mini mental state exam. B, Glasgow Coma scale. C, Denver developmental screening test. D, Vanderbilt ADHD diagnostic rating scale. What do we think? The tool that is commonly used to assess cognitive function. This is something you have to know, and this is very, very straightforward and an entry-level exam. It is the mini mental status exam, examination. So now, A, final answer, but what is GCS used for though? Okay, let's keep in mind, what is GCS used for? Remember, when we have patients, when they are in the neuro unit and they have some kind of neurological damage, we're going to do neuro GCS on them. The Denver Developmental Screening Test and the Vanderbilt, these are all pediatric assessment tools. These are pediatric assessment tools. A, final answer. Okay, just keep that in mind. What MMSE is, they're going to integrate it into your test question. Let's look at question number 3. 82-year-old patient with CKD. In your mind, you're thinking, what the heck is CKD? You got to know what CKD is, be familiar with the pathophysiology of CKD, and then you'll be able to approach any CKD question. Is prescribed what? Gentamicin. Which consideration is most important? A, standard adult dosing is safe. B, dose adjustment based on renal function. C, always double the dose for efficacy. C, D, avoid monitoring drug levels. Drop your answers in the chat, please. What do you think the physician is going to do? You will not be the one to do this. You know, you will, but the physician will do the job. But you have to anticipate what they're going to do. It is our job to know what they're going to do. Drop your answers in the chat. Absolutely. I'm so proud of you guys. Like, you know the basics. You got this down. The final answer is going to be B. 100%. 100%. Okay. Okay. 100%. This is wrong. What is the protein binding capacity when it comes to our geriatrics? They tend to get what? They tend to get toxic easily because they don't have enough protein to bind to that drug. So they have a lot of free-flowing drugs that will end up in their system and can create and it can cause toxicity. Always double the dose. Are you seriously kidding me? This is killing them right here. Avoid monitoring drug levels. Negative. B, final answer. Question number 4. An older adult is taking warfarin and amiodarone. What is the very main concern? A, increased risk of bleeding. B, increased risk of clotting. C, increased no significant interaction. D, reduced efficacy of warfarin. What do we think? Drop your answer in the chat. Don't forget, amiodarone there's a concept called inducer and inhibitor. Okay. You also should remember there is a concept called what? Pharmacokinetics and pharmacodynamics. Now, pharmacokinetics, okay, is the movement of drugs from point A to point E. That is where we have the ADME process. Is the movement of drug from point A to point E. That is the ADME process. So guess what? Amiodarone, okay, happen to be what? An inhibitor. This is something that you must just know now and as a clinician, period. Amiodarone is an inhibitor. An inhibitor will do what? We raise the level of the other drug up. So amiodarone being an inhibitor, when we mix it with warfarin, that is danger. Guess what? It is going to increase the level of warfarin, causing the patient to bleed. A, final answer. I didn't tell you everything about this, but hey, this inducer and inhibitor came from the concept called metabolism. During the process of metabolism, we have two things that can potentially happen. The drug that we take into our body can be induced or can be inhibited. Our drugs can be induced or can be inhibited. Dr. Kehinde Elisha speaking here, CEO, founder of NP Certification Academy. To reach us, nurse-to-nursecoach@gmail.com or www.npcertificationacademy.com. This is a paid review. If you have not paid for this review, you may now exit. Please be ethical. This is a paid review. We have staff that we pay. This is my only job. This is not a free review. Do not bring your friends. Do not bring your family. Do not bring your coworkers. Do not gather behind the screens. This is a paid review. Please, if you have not paid for this review, you may now exit and go online and book on www.npcertificationacademy.com. So A is the final answer here. It is not increase risk of clotting. It is not, of course, there's some kind of interaction going on. It is not reduced efficacy. It is definitely because amiodarone, in fact, is an inhibitor, and it's going to raise up the level of warfarin, leading to a bleeding risk. Next question. 85-year-old is a keyword. Patient present with shortness of breath, peripheral edema, and jugular vein distension. Which is most likely diagnosis? A. Congestive heart failure. B. Myocardial infarction. C. Pulmonary embolism. D. Chronic obstructive pulmonary disease. What do we think, providers? Please drop your answer in the chat. Shortness of breath, peripheral edema, jugular venous distension. Do you see my point now? This is the same thing that will happen to everybody's system. Geriatric, pediatric, maternity, we're still going through the same body system for regular population. Does it make sense now? A. Final answer. Congestive heart failure in kids, geriatric maternity presents the same way in everybody. Myocardial infarction presents the same way in everybody. Pulmonary embolism presents is still clot in everybody. Chronic obstructive pulmonary disease presents the same way in everybody. Now, what I want to quickly say is pulmonary embolism. How else can they present the question on the exam? We have the PQRST with EKG. If we have time, we're going to do cardiovascular system tonight, and you can actually connect with me a little bit on some of this concept. So when we have PQRST, right, the ST segment, if it is above the isoelectric line and a little bit high, that is called the MI. That is called myocardial infarction. If the ST segment is below the isoelectric line, it is called what? Myocardial ischemia. It's called ischemia. So something is rotting if it's down in the dump, and then something that is aiming high is called MI. Now, with pulmonary embolism is some kind of clot. Some kind of clot will now block the blood vessel. When it blocks the blood vessel, blood cannot flow. So when we have pulmonary embolism, it happens to be in the pulmonary system. However, embolism itself is a clot. A clot can go anywhere in the body. If the clot goes into the head, it causes a stroke. If the clot goes to the heart, to the lungs, it causes what? A lung attack. So what we call a stroke is actually a brain attack. And what we call and then if the stroke also go to the heart, it's going to cause a heart attack. So now the clot is a big deal. And the one that we call a clot is a embolism. Now we do not have anything that says that will connect us that, okay, this is definitely a clot. So we can't say that. So the only thing here is going to be congestive heart failure. Sometimes apart from this jugular venous distension, you know what else they're going to also put? They're going to put that when you auscultate, you were able to hear S3 sounds. That is another way that they're going to get you with, okay, they have congestive heart failure. A, final answer. Now, which statement is true regarding pneumonia in older adults? Fever is always present. Confusion may be the only presenting symptom. Cough and sputum production are always prominent. Respiratory rate is unaffected. Clinical nurses, drop your answers in the chat for me. Checking your answers right here. I'm getting 100%. This seems to be too easy for everybody, okay? Maternity is going to follow this one. So let's see how we're going to do on maternity. Of course, B, final answer. Okay? You know, any kind of bacteria infection, even UTI, can be a source of confusion. Any kind of bacteria can cause confusion. It might be older adult present atypically with confusion or lethargy instead of classic respiratory signs when it comes to some kind of infection. Okay? Now, a 70-year-old patient present with polydipsia, polyuria, unexplained weight loss. Now, this is exactly the same way we're going to describe this symptom in a regular population. Please type yes in the chat if you kind of get my point. That tackling these special populations, you're also actually tackling other populations. Do you all get me? That is what I'm trying to say. I target a special population, But honestly, it is other populations too, because the body system is body system. Your heart is the same thing as an 80-year-old heart. Your heart, your lung is the same thing as a 10-year-old lung. Your legs and arms is the same thing as a maternal arm. So it doesn't matter. Doesn't make sense. So when we talk about polydipsia, polyuria, and unexplained weight loss, what do we think? This is exactly how we describe what is type 2 diabetes. What is type 2 diabetes? So a 70-year-old polyuria, polydipsia, unexplained weight loss, type 2 diabetes mellitus. Fasting blood sugar 180, absolutely, boom, we are done. Now, type 2 diabetes is the final answer. Type 2 diabetes is common in older adults. I'm going to present with classic hyperglycemia symptoms. Of course, incorrect answers, hyperthyroidism can cause weight loss instead. Type 1 diabetes usually presents in youth. Be careful. SIADH can cause hyponatremia, not hyperglycemia. So listen, we have type 1 and type 2. Type 1 is also what we call what? Juvenile diabetes. It is something that happens to children. It's something that happens to kids. That's all I can say. Now, which symptom is most suggestive of depression in older adults? A, persistent low mood, fatigue, social withdrawal, short-term forgetfulness, sudden onset of psychosis, hallucination with acute infection. What will you see in an older adult that will look like, she looked depressed. I think she's depressed. What will you see? All right. I'm looking at the answer now. 100%. 100% persistent low mood, fatigue, social withdrawal. That is the same thing that we see in our population, something called CG-CAPS. CG-CAPS, sleeplessness, interest loss, guilt, helplessness, worthlessness, psychomotor agitation or retardation. These are things that we're going to see in our geriatric population that are depressed. Short-term forgetfulness, sudden onset like psychosis. That this may be true, but this is the complete answer. On your exam, you have to look at the options. Okay, which option is complete? Which option is complete? Does it make sense? So now, a 80-year-old patient falls at home and complains of hip pain. Which assessment is most appropriate? First, A, pelvic X-ray, B, MRI of the brain, C, abdominal ultrasound, D, chest X-ray. 80-year-old keyword, falls keyword, at home and complains of a hip pain. What are you going to do for this patient at this time? Please drop your answer in the chat. Falls at home, hip pain. Yes, you're not the one prescribing it, but you must be able to anticipate what are they going to do for this patient at this time. Excuse me. Of course, we need to take a picture of it and check it out. Is something broken? Why wouldn't you want to pick MRI first? You don't ever want to pick MRI first. Number one, it's very expensive. Okay. Now, if this 80-year-old, if she busted her head and now the brain is messed up and they want to check out the tissues in the brain, then we can definitely, pick MRI. But if it is a bone, we suspect that a bone broke, then we're going to be doing X-ray. A, final answer. Abdominal ultrasound is not related to what's going on here. Chest X-ray is now related to what's going on here. They said the patient broke a hip, so that one is more definitive. So we need to face what the problem is. Okay. Which intervention is most effective for preventing falls in older adults? Now, safety. That is what your exam is all about. So listen. On that exam, if you can't think of anything, think Maslow. If you can't think of anything, think of how to keep your patient safe. Maslow's hierarchy of needs, what is it all about? Maslow's hierarchy of needs states that human wants are insatiable. So now, we don't want to be seeking self-actualization when we are trying to meet our physiological need. So physiological need and safety takes priority under Maslow. So we've also adopted, in nursing, we've kind of like taken on that concept that Maslow, we have to hold on to it real tight and make sure we are meeting the top needs before we think, you got to meet your physical and physiological needs first. You got to be able to feed before you start thinking of becoming a president. That is what Maslow is all about. So even though we can never be satisfied at a point, we just have to know that, okay, we are not ready to move forward. We need to eat first before we try to worry about what I'm going to wear, or what I'm going to, or looking good, or whether I'm going to, become the governor of some state someday. So now, this one is now saying intervention. What is most effective for preventing falls in the elderly? Home safety assessment and removal of trip hazards, routine bed rest to prevent injuries, limiting fluid intake, avoiding walking independently. What is now, everything is great. Everything is great. Right now, all this option is great. Will you all agree with me? The question keyword that you must not miss: what is the most effective? What is the most effective? With all my answers here, what is the best thing that you can do to keep me safe? Drop your answer in the chat. Okay, I think everybody's pretty much on the same point with this one too. Home safety and removal of trip hazards. Now, bed rest to prevent injuries for how long? Limiting fluid intake for what? Avoiding walking independently. Okay, what are we doing there? Then we're going to be losing the muscle if we don't use it. A is the final answer. 11. A 79-year-old patient presents with SOB at rest, edema in both legs, weight gain of 4 pounds in just 2 days. What is the priority nursing intervention? A. Administer intravenous diuretics as prescribed. B. Encourage the patient to increase fluid intake. C. Obtain chest x-ray in 1 week. D. Recommend a high sodium diet. Listen to the keywords and follow the keywords. The population here is a 79-year-old patient. SOB already. Edema in both legs, so they are retaining fluids. And then this is looking like what kind of a patient again? This is sounding like a cardiac patient to me. Okay? Right off the bat, you got to think, what kind of patient am I looking at? This is looking like a cardiac patient to me. What is the priority nursing intervention? Administer intravenous diuretics as prescribed. Encourage the patient to increase fluid intake. Obtain a chest x-ray in 1 week. Recommend a high sodium diet. Okay, what do we think? This is a cardiac patient. Most likely, what is the diagnosis of this patient? What do you think? What do you think they have? What do you think is going on with this patient? Fluid overload, but I need a specific diagnosis. Okay, Mr. Lu, CHF. CHF, they definitely have CHF. A, final answer. If we're not talking about intravenous diuretic, like, drop your answer in the chat. Like, example. We know the diagnosis as CHF. No, what drug? Lasix, furosemide, Lasix, the same thing. Excellent. Excelente. All right. Excellent. A, final answer. So look, rapid fluid retention indicates acute decompensated heart failure, period. Diuretics relieve symptoms and prevent complications. Increasing fluid when they're already loaded on it. Chest x-ray is useful, not immediate priority. Sodium restriction is recommended, but high sodium worsens edema. A 72-year-old patient has blood pressure of 162/88 in routine check. Which lifestyle modification should be prioritized? A, reduce dietary sodium and increase physical activity. B, avoid all carbohydrates. C, limit fluid intake. D, stop all medications. What do we think? Okay. Are we all agreeing with that? Routine check, lifestyle modification, what do you want to prioritize? Blood pressure is already high. Avoiding carbohydrates, well, that sounds okay too. Limiting fluid intake, that one is not even like, it's not a point at this point. Stopping all medications, this one is just ridiculous. Now, you want to go ahead and remove things that you know it's definitely not going to be. I see that most of you put in A. A only makes sense at this time. We're going to reduce dietary sodium and, of course, increase physical activity. A 75-year-old with chronic obstructive disease presents with increased sputum, squeezing, shortness of breath, oxygen saturation is 88%. Which is the priority intervention? A, administer supplemental oxygen and bronchodilators. Begin oral this is a respiratory question. You see what I'm saying? This is a respiratory question. So you got to have a respiratory system knowledge to connect with this. Administer supplemental oxygen and bronchodilators. Begin oral antibiotics immediately. Encourage bed rest only. Perform chest physiotherapy. Only is a bad red flag. Do you all know what I'm saying? As in, unless you absolutely don't have a choice, don't be picking answers with only. Don't be picking answers, you know what I mean? Like, only, which other keywords am I always supposed to be looking for? I will come up with a list of the answers for you to just know that, oh, this cannot be. You know what I'm saying? There is all, something like that. Thank you so much. All, some kind of ridiculous points like that. Like there is no way or the highway kind of a thing. Is not going to be the answer. So automatically, those are red flags. I didn't even read what they are. But when I saw this only, that's it right there for me. They're out. So if I have to look into options, I'm going to look into A and B. So what do we think? Excellent. This thing keeps spreading all over the screen. Okay, excelente. A final answer. Okay, COPD is what they have. They need bronchodilator, they need O2. However, we cannot get... Okay, now let's talk a little bit about this. When a patient has COPD, don't forget, when a patient has COPD, okay, that CO2 that is building up in their system is what is actually helping them breathe. So CO2 is the hypoxic drive. It's called the hypoxic drive for somebody with COPD. Carbon dioxide is the hypoxic drive for somebody with COPD. What does that mean? You must not go beyond 6 liters. You even try not to get to 6 liters for somebody with COPD. We don't want them to hit 100%. We don't want them to hit 100% when we give oxygen. Very, very important. A is the final answer. A 78-year-old patient presents with fatigue, constipation, bradycardia, and cold intolerance. Which lab test is most appropriate to confirm the diagnosis? Thyroid stimulating hormone and free thyroxine, serum glucose, serum cortisol, complete blood count. What do we think, future nurses? I think you'll find this one too easy. Now let's talk about the diagnosis though. So what are you suspecting this patient's got? What are we trying? What case are we? What is in our hand at this time? Is it hypothyroidism or hyperthyroidism? Excellent. So if it is hypothyroidism, it makes sense to go what? To do TSH and free thyroxine. A final answer. If you pick C, you are close, but not really. This is a stress hormone that can cause all of this situation too, but this is pointing us to hypothyroidism. A final answer. Okay. So primary hypothyroidism is confirmed with elevated TSH, low free thyroxine. Glucose evaluates diabetes, not thyroid function. Cortisol evaluates adrenal disorders. CBC does not diagnose hypothyroidism. Let's go back to that lab. What lab? Okay, let's go back to that lab. Okay. There is a lab, okay? Don't forget, when we have people with thyroid issues, we have T3 and T4 or TSH. How do you interpret this lab? When somebody have hypothyroidism, this T3 and T4 is going to be on the low side. It's going to be low. This TSH is going to be on the high side. There is always an inverse relationship between T3, T4, or TSH. When T3 and T4 is low, TSH is high. When T3 and T4 is high, TSH is low. So you must know that from now on until you get your doctorate or until you finish practicing as a nurse. T3 and T4 have an inverse relationship. T3 and T4 is low, TSH is high. So listen, even though we call it hypothyroidism, TSH level is high. Be attentive to that. So TSH is the opposite of what we actually think. TSH is the opposite of what we actually think. Are we good? All right, let's take a look at the next question. 70-year-old patient with type 2 diabetes report frequent hypoglycemia while taking glipizide. What is the next best step? Evaluate for dose adjustment and alternative therapy. Stop all medications immediately. Encourage skipping meals. Increase glipizide dose. What do we think? This is too much to be, it's just too much. It doesn't make sense, right? The only thing that makes sense among everyone is A, final answer. 82-year-old patient reports loss of interest in hobbies, poor appetite, and insomnia for 3 months. What screening tool is appropriate for this patient at this time? A, geriatric depression scale. B, mini mental state examination scale. C, Pittsburgh sleep quality index. D, Beck anxiety inventory. Think about it though. Insomnia, loss of interest. You want to first of all think, is the patient, what is going on with the patient? What is the diagnosis of this patient? Because I see that many people are picking mini mental status exam and scale. Okay, now we are talking. What is going on? What is your diagnosis for this patient though? Don't forget, patient have depression. If the patient have depression, we're going to do geriatric what? Depression scale. A, final answer. MMSE is for what? To screen for cognitive issues. Sleep is to screen for sleep. Beck is for depression as well. I mean, we also have Beck anxiety, we have Beck depression, but this one is saying Beck anxiety. So the final answer is A. A 79-year-old patient in the hospital is suddenly confused and agitated and distorted, which developed over 24 hours, which vital sign shows fever. What is the most likely? Which is most likely? 79, hospital suddenly confused, agitated, disoriented, and this all developed within 24 hours. Okay. What is the most likely diagnosis? A, delirium, Alzheimer's, dementia, normal aging, Parkinson's disease. This is your patho. Grab your patho here. These are all patho questions, like mostly patho questions. What do we think? We're not even taking decision yet. For you to be able to take decision, you must solidify your patho first. I love your keywords: suddenly confused, agitated, disoriented. Suddenly. And it developed over 24 hours. There are two types of cognitive issues. There is delirium, there is dementia. Okay? Dementia, you take the TIA, we share its space. So dementia is more prolonged. Delirium is acute. Delirium is what? Is acute. Delirium happens in a very short time. A, final answer. This is not dementia. This is delirium. It happened in a short time. Does it make sense? Okay. Now, 85-year-old falls at home and can now bear weight on the right leg. Hip is externally rotated and shortened. What is the priority intervention? A. Stabilize the leg and prepare for surgical repair. B. Encourage ambulation to prevent stiffness. C. Apply heat packs. D. Administer oral pain medication. Cannot bear weight on the leg. Hip is externally rotated and shortened. How do you now prioritize? How do you now intervene? You can intervene in so many ways, but what is the most important intervention at this point? Okay, we got to stabilize the leg and of course prepare for surgical repair. That one is straightforward. 77-year-old patient presents with brief loss of consciousness while standing and quickly regains alertness. Which is most likely cause? A. Orthostatic hypotension. B. Stroke. C. Seizure disorder. D. Myocardial infarction. What do we think? I'm seeing 100% right now. I'm seeing 100%. Brief loss of consciousness, but they were trying to stand at the time. It is orthostatic hypotension. Orthostatic hypotension, what is it then? It's a transient syncope upon standing and is classic for orthostatic hypotension, common in older adults and especially with medications. Now, which lab value is most important to assess renal function before prescribing a nephrotoxic medication? A. Estimated glomerular filtration rate. B. Blood glucose. C. Serum sodium. D. Complete blood count. What do we think? Okay. Excelente. EGFR. All right. We're going to take the last question quickly. I think that was the last one, 20. All right, so we're going to stop right there for now. I said we're going to do 20 questions. It kind of got prolonged because I had to break down a lot of concepts, but I hope you learned along the way, though. Don't forget, what are your strategies on the NCLEX exam? There are many exam types, question types. And then those question types, you have to pay attention to how to approach them. Okay, extremely important to pay attention to how to approach them. Most importantly, if you click next, you can go back. It's a computer adaptive test. Please, please, please. For your SATA questions, don't be picking A, B, C, D like that. If you're only sure of B and C, pick it and keep it moving. If you're only sure of A, pick it and keep it moving because you're going to get a partial grade on that. All right? At this time, we're now going to switch gears to maternity questions. Thank you.